Everybody, happy Monday. Hope you all had a wonderful weekend. It was extremely cold here in Georgia. We got down on Saturday to right around 5 degrees with the wind chill. Broken pipes at this guy's house with lots of water running across the floor. But we got it sorted out and minimal damage compared to what it could have been. But anyways, we're here. We have three great topics for discussion today. As always, I want to begin by saying thank you all so much for tuning in, logging on, and just hanging out with Terry, Paul, Scott, Christine, and myself. Stephanie is off today, and we will definitely be missing her, but she will be back with us next week. So, Terry, I'm going to put you into the main Hollywood Square for the first topic of conversation today. So, take it away.
Okay. Hello, everyone. We're all happy you're joining us. Yeah, it's freezing here today too, 55 and raining. Sorry. Just I'm in California. I can't help myself. We're cold though. I never wear long sleeves. Today we have it. So we have a couple of topics today that I want to bring to your attention because they're in the forefront. They're basically hot topics and just things that we constantly get questions on, either through email or through our memberships, through direct messages. Boy, we get them from every possible way. People find us. It's hard to walk into a restroom nowadays without people going, "Hey, are you Terry Fletcher? I have a question." So it's kind of funny to me. But one of the things I wanted to first start with is the fact that one thing that's really hard to respond to a question, and it'll kind of lead into the second topic too, and I want to put it out to the panel, is when CMS forgets to cross reference their information. So, perfect example, we have new time thresholds for E&M services. So, instead of saying a 99205, for example, is 60 to 74 minutes, it says that it's 60 minutes that you have to meet or exceed. Okay, that's fine. They're trying to match it up with the hospital services. But then when you get into prolonged services, remember Medicare has a G code, G2212, and the CPT book for commercial plans have two different codes, 99417 or 99418, depending on the place of service. Well, they didn't agree with their application of that code. Medicare said you had to meet the maximum time when we had the range, and CPT said you had to be 15 minutes after the minimum time, which made no sense to me if you've got a time range. But now that we have a meet or exceed, it seems like now the CPT version is appropriate, but Medicare kept their time range. They forgot to cross reference for the prolonged services. So, what do you respond to a practice that says, hey, it says we still can't add the G2212 to a 99205 unless we've hit 89 minutes? I said, well, you have to follow published guidance. They said, yeah, but that's not what CPT says. Sean and I talk about this a lot of times on Terry Tuesday. And CPT is a great source of information, what codes we bill, how to send them out, their direction, and how to do that. But they are not payer guidance. They don't deal with bundling issues, except if there's an inclusive code. They say, this includes this or that, but they don't deal with coding edits. So you have to look to the published guidance. And if it is conflicting with CPT and you're billing Medicare, that's what you go with. And so you have to understand that. Now, what if you don't have published guidance that's addressing this issue in a commercial plan? Then I would say you may be able to default to CPT, but you have to make sure you've got something you're defaulting to within your compliance plan, your policies in your office, so that in case it's ever questioned, that you can go back to that. Which I'm going to throw this over to Scott, because Scott, you've got to see sometimes where something is said or something's changed, let's say in CPT, and then Medicare forgets to update their policy, or Medicare just forgets to cross reference. Have you seen? I mean, consults is a big one. Consult codes are a big one.
Yeah, I mean, I think you're spot on. At the end of the day, like the first thing you should always be doing is figuring out what your payer says about that specific code, says about that specific service type, and that applies to everything, right? Whether it's like frequency or do we pay for this, do we not pay for this, and if you're not doing that, and again, I hate to just be the affirmer, but I think you're really spot on in terms of like the CPT book is what the AMA would like it to be, and I think the payer is going to inevitably disagree, or some payer. And I feel like, a lot of times the most common disagreement, right, is CMS and the AMA. And CMS kind of has the, it's almost like I don't know if it's like a reverse card in Uno, right? Like they have their own code set. They're like, well, I'm going to take a G code, slap it on the table, and I'm going to do it like my way, right? And so, it's one of the challenges of the work that we do. And I think it's one of the challenges, particularly when you work in a practice and you get to when the calendar changes over and you just got a lot of information coming at you in terms of like, this is a change for 2024. Just take a step back and say, what does each payer pay? And again, not to just be the affirmer, but consults have always been a great example of that, where, consults are like the dinosaurs, right? Like we had a bunch of them 20 years ago, and now we've got like two, and in a few years we might not have any. But you still have to understand, if the payer is paying for consults, there are certain requirements behind that, and you can't just say, well, I found out the payer paid for consults and I'm just going to bill it, but I haven't met all these requirements. Like every payer and every code set, they can't, for HIPAA purposes, just take a code descriptor and modify it, but they can certainly modify the payment rules and the frequencies and those things.
Well, and I think before you get into this, Paul, because I want to throw it back to you, one thing that's really a big difference is CPT time threshold and what CMS thinks of time thresholds. Remember, CPT allows for you to round up, I guess it is, or to meet a certain amount before it says this. Perfect one I deal with all the time is moderate sedation. Moderate sedation says you have to meet 15 minutes, but then in the fine print and CPT, it says, but if you meet 10 minutes, you're okay. Well, Medicare says we want 15 minutes. And
Yeah.
so there's things like that.
Yeah, and I think the issue with the prolonged services at the outset was the AMA's position was like, once you hit that prolonged service, that 75th minute, right? If we're using 99205, so if you're at like 75 minutes and 6 seconds, go ahead and slap on like 99417. And CMS said, well, wait a minute, right? And I don't think that's really changed with the removal of the ranges, and it's just a different approach. It's CMS basically saying, look, like, we feel like you can't get like right over the finish line and get the entire amount. You've got to get through the entirety of the prolonged service. And as I say to a lot of my clients, right, like, I'm in the business of telling you unreasonable things sometimes, but these just happen to be the rules that we work with. And if CMS says, like, we don't think it's reasonable, the minute you cross that threshold, we're going to give you that extra money, then they're within their rights to do that.
Okay, well, I'd like to pick it up from here. Believe it or not, despite my haircut, I'd like to give you a lesson in advanced math. So we have CPT code, as an example. We have CPT code 99205, and that says that if you want for prolonged services, you need at least 75 minutes of time, I believe, is the threshold. Well, the curveball here is, you mentioned, Terry, billing an E&M service with that dreaded G2211 that everybody is simply falling in love with and wanting to use improperly. It's important to point out that G2211 does have a time value based on the 2024 physician time file under the Medicare Physician Fee Schedule final rule. And it's valued at 11 minutes. It's because it's an add-on code, all 11 minutes are classified as immediate post-service time. So if you're thinking of billing an E&M service with G2211 and then wanting to take the dive to prolonged services, I would add 11 minutes on to anything that's in CPT that would add that. Because you're really going to be crashing into things. And G2211, quite obviously, is not going to be listed in CPT because it's a HCPCS code. So watch out for that time addition. And, I again, as I have for the last 10 years, please go to the Medicare Physician Fee Schedule final rule page for 2024 and download that physician time file. It's going to save you a lot of heartache, and it'll give you a lot of things to think about as far as how CMS values those services. Because 55 minutes under 99215 is actually 70 minutes when you look at that spreadsheet, because they're including pre-service time. So it's an interesting dive, and I won't even get into how I use that for the modifier 22. That's a whole other episode.
All right. So, Christine, I want to get some of your thoughts on this, and then I want to go back to a topic of consultations before we move on to our next one, because we just need to. So, Christine, let me kind of give you the floor and take it away.
So I think you hit it spot on there, Paul. I think it's important to understand the anatomy of that CPT code from the payment perspective. And there's a huge rabbit hole that you can go down to, but Medicare does give us a wonderful set of guidances every year with that final rule that breaks down so much of what's already built into those CPT codes. So I think that might be a good way to start with providers as well, is say, listen, I understand we're very frustrated about when we can report additional time and Medicare patients versus commercial patients, but let's really take a look at what's going on with this particular CPT code before we feel like we're not getting what we're expecting to out of it.
Yeah. I just, knowing how much time we spend with physicians, educating them, shadowing them, especially when we go on site to the hospital networks and the health systems that, have employed physicians. I think about how unrealistic some of these time thresholds are, because these physicians, so many of them are so efficient at performing the key elements of a service that it's almost as if, and this is just my opinion. They're almost as if they're being punished for being efficient. It's like me sometimes, right? I had a case where, they said, the witness for the prosecution was on direct, asked how long they took to do the work for the case, and Paul and I kind of laughed when we heard this number. Their witness claimed that they spent 300 hours preparing for a case. Okay. And I'm not making this up. There were only 10 medical records that were in question for this federal False Claims Act case. But this witness, their expert, claimed they spent 300 hours. When I was on the stand, they asked me how long I spent on the case. I had a total of 32 hours in on the case. Now, we prevailed. Our client was acquitted because they were not guilty. But I look at it the same way with these providers who are efficient. They're doing what they have to do, but yet because there are these rigid thresholds and these expectations of how much time somebody is supposed to take to get to a certain level, without taking into consideration that we have Dr. Slow, Dr. Fast, and Dr. Very Fast, and each one kind of moves at their own pace. It's not right to, in my mind, punish those who are efficient, who are doing great documentation and moving their visits along. Now, the last thing that I want to say, and I know Terry was like, "Oh God, Sean, please don't." Consults. I understand why consults were taken away. I do. I get it. They were abused by providers. They were billed incorrectly. The documentation didn't support it. They didn't have the 3 R's of the request, the render, and report. So it led to a lot of problems, right? But by CMS, with their infinite wisdom, saying, well, we're just going to do away with it, as opposed to trying to educate providers, it has created so much more of a mess, in my humble position, especially in situations where we have patients that are being admitted into the hospital where certain states aren't recognizing AI modifiers. And as a result, you have no way to allow the providers to bill for that crosswalk. And Terry, I know you're going to come after me on this because there's 5 levels of consults and only 3 levels of this and that. But CMS's guidance was explicit that you use the 99221 through 99223 for any consulting physician. I really hope that CMS will put consults back onto the discussion table so that we can get these codes that are so necessary back into the system with proper education to physicians, because these crosswalks, in my opinion, have fallen willfully short of what they should have done. And Terry, just before you tell me, you start hitting me over the head like a hammer on a nail, I don't disagree with you. Okay. I don't. So since I've been picking on Terry because I knew she was going to beat me up, I'm going to let Terry have the first word.
Well, when they first took out consults, they also said, and there was actually a published MLN on it, and I've been looking for it for you, but because again, that was now 14 years ago. They basically said that yes, you're supposed to use the 99221 to 223 with an AI modifier, which meant admit inpatient, for the primary physician or principal physician of record. And then if you are the consulting physician, you're supposed to use the same codes without the modifier, or it was very clear, or the subsequent codes, because there was not a direct crosswalk, again, because 5 levels versus 3 levels. And if you didn't meet that, you had to bill what you met the criteria for in the documentation. And let's face it, the history and exam for the 99221 to 223 is different than the 99233 to 231. So they did put that in some of their published guidance, and it didn't make sense because, the 99233 to 231 was for subsequent visits. And if you never saw the patient, that didn't really make a lot of sense. But because there's no new and established patient in the hospital, it does make sense where you have to do what you documented. And now, luckily, since I think just last year, 2023, now it's about this during the stay. It has nothing to do with the admin or whatever. But consult codes, I agree with you, Sean, on this part. I think the fact that they eliminated them because some of the bad actors, I think that was a problem. And then, of course, a lot of the commercial plans and a lot of Medicare Advantage plans or payers that also represented some Medicare payments, they said, oh, those are so expensive and we pay more than that than we pay for other codes. We love that rule where we don't have to pay consults. And, I think a lot of payers jumped on that. It's rare now I find a payer that pays a consult. So I'd be surprised if they actually put it back on the fee schedule. But once they take something out of CPT, they've got to put something in. There's this balance thing,
Yeah.
So
am I incorrect? Am I incorrect? Because I thought CPT still maintains the consult codes.
They do.
They do. Okay.
But payers don't necessarily recognize them.
You.
Yeah, we just have payers that are just like, no, we follow Medicare rules, which is very selective, by the way. And I know the whole panel sees that. As soon as a payer doesn't want to pay for that from a commercial payer perspective, they're like, well, we follow Medicare rules. We're like, well, you kind of don't. You might on this one topic, but you didn't on this other thing over here.
I will tell you something, Terry, and Paul will agree with me on this. This drives me absolutely insane. You cannot say you do not follow Medicare guidelines, but in your published guidance say, we are following Medicare guidelines for the purposes of consistency for this issue.
Right.
But, and then they come back to you and they say, well, we're quoting directly from the AMA. And then when you show them where they only gave you a partial quote from the AMA, and here's the actual full quote, then they don't want to follow AMA guidelines.
Well, you should try a California work comp. It's the same thing. California work comp a few years back decided to go by Medicare guidelines and not by our fee schedules here, which are totally different. Work comp is completely different state to state. And so they changed it where we're going to go by Medicare guidelines until they figured out that Medicare pays more than some of them. California work comp, we found that the fee schedule was from 1984. And so they're like, oh, no, we decided not to go by Medicare guidelines for payment, but just for policy. I'm like, wait a minute. So yeah, so just I know we're getting off topic because
Nope.
there is a couple
All
of
right.
things I know we want to get to, but
All right. Yeah, but
yeah.
I'm reading a lot of the comments and folks are right on board with us. So I'm glad to see that a lot of what we're talking about is resonating. All right, let's move on to topic number 2. Who wants to lead that one?
I think we should throw it to Christine. That's hers. We tried to do it last week or the week before last, and we didn't get to the social determinant of health.
Yeah.
Oh,
So
social determinants of health. Here we go.
I was recently doing an education on the social determinants of health assessment, not screening, assessment. But I also noticed that they updated the MLN on annual wellness visits to advise us that starting July 1st, when that social determinant of health screening is done at the same time as an annual wellness visit, that they're going to waive that financial responsibility for patients. Allowing this twice a year, but only once if at the annual wellness visit will they waive that financial responsibility. So it leads me to believe that with all the changes that we've seen since 2021, as we start talking more and more about social determinants of health, that we're really seeing healthcare move into that direction where we recognize that there's so many things that are deterring patients from being able to successfully follow a plan of care or improve their own situation. And one thing that I want to say is I think that we also need to make sure that if we've identified through assessment or identify in the evaluation and management that there are social determinants of health, I can't afford that medicine, I can't get rides to and from the office timely, that there needs to also be a resolution that's being documented. If not, what's the relevance in even mentioning it or even assessing it if you're not going to try to move forward? So do we think that more practices might get involved with looking for those solutions, Meals on Wheels, taxi services, discount coupon cards for medications? How is that all going to play out as we start to really use these new SDOH assessments? That's my question, more of an answer.
Yeah, and also I'll just mention it too. Remember, for those of you who don't know what this is an assessment that
thanks,
is,
Carrie.
yeah, it's GO 136. And Christine, it's every 6 months, 3 to 6 months or 6 months?
Every 6 months
Every
that
6
it'll
months.
be reimbursed.
Yeah, and it's
And
not
then,
an
of course,
add-on
after
code,
July
people.
1st, it'll be
Right.
covered during that annual wellness.
Right, and it's not an add-on code. And remember, this is worth $19.80, basically average. And it's not an add-on code, it's a standalone code. So if the social determinant of health, like not being able to afford your medication, is affecting your patient's ability to, get their prescriptions, or being homeless, they can't get access to care, things like that, it has to be on that, SDOH approved list of diagnoses. So if that is affecting or impacting their care that your provider is dealing with, and every 6 months this assessment is appropriate to include, if it's also part of that documentation. But make sure that you're careful, because the patient, if it's during an E&M service, they have an out-of-pocket. If it's during the annual well visit, then it's, to me, I agree with Pam here, it's really a screening. But they don't have any kind of out-of-pocket limitations or out-of-pocket expense. And so, Paul, to you on this code. This is an interesting code to me because I think it's important, but I think it's going to be not abused. I don't like to use that word all the time, but I think maybe misattached to services.
Well,
Misunderstood.
Well, 3 things I want to point out about this code. There is an indicator in HCPCS that this is reimbursed at carrier discretion. So you want to go to your MAC website and make certain that there is reimbursement for this code. Second, there is no bundling edit between this and an E&M service, so that is a positive. And the third thing that I would point out is that it is a time-based code because the definition says 5 to 15 minutes. So you most definitely, in your documentation, if you are doing a social determinants of health assessment with some type of screening tool, that you indicate the time that you have spent on that, so it is considered separately from the medical decision-making portion, moderate complexity, the right-hand box. Everybody knows what that is.
I have a question when you said that. So if it's included in or if it can be billed with an annual well visit, and those are also on the telehealth list, how do you get the time?
Well,
I mean, I don't understand.
In the same way you get a smoking cessation credit by saying,
like, where
let's,
do you get the time here?
Ever seen the TV direction? Stretch.
I know.
Stretch.
I know. Well, also, a lot of times we talk about on the compliance guide, we talk about compliance plans, compliance policies, written direction for your staff on how all this works. You need to have an internal policy because, as Christine said, and Paul mentioned, I'm going to throw it to Scott too, I know he's a thought on this, is that so if you report it with an office visit, there's an out-of-pocket for the patient, a share of cost. If you report it with an annual well visit, there isn't. And patients know what's free to them. They know what they don't have to pay for. And so they may not be happy if you are reporting it. What I didn't see in the final rule is that what if multiple physicians are using the same social determinant of health diagnoses to report the code that it affects there? Will they pay for multiple physicians? So Scott, I'll throw it over to you. I think there's a lot of policy issues on this that are going to be a problem.
Yeah, and maybe I'm being idealistic because it's a Monday morning, but my concern with this code, like you had mentioned abusive and then said you didn't want to use that word. Like I think the word I think about with social determinants of health, and I wish maybe that CMS valued it a certain way, is like purposeful, because this is a code that is a 5 to 15 minute. You can maybe do it twice a year. It's free with a wellness visit. And Terry, you had mentioned some things, Meals on Wheels. Solving a social determinant of health concern, I don't think is something that's easy to do in 5 minutes, like a real social determinant of health concern. And the reason I say idealistic is because my experience tends to be as an auditor, some providers are very passionate about these things, like helping connect patients to cheaper medications. Like I can sit you with somebody who maybe can help you get a coupon to waive a copay. I can get on the phone and try to make a call. And some providers, I don't want to say they're not, they just maybe don't have time. Maybe the practice is too busy. And so my worry with a code like this is that one, you don't accomplish a lot. And so when you think about it, just becomes another thing you tack on, and it doesn't really accomplish a lot, for the patient, or that the physician turfs it out to the staff when the intent of the service is really that the physician is the one who's doing the work. And so I think you've got a couple of concerns there. And I mean, I could almost relate it to consults, right? Like it's like you kind of know the purpose of a consult, the purpose of this. And the question is, do you really try to solve it, or do you just try to get this extra code on there? And again, right, like I don't want to cast aspersions on anybody, but I think as I've done this work over the years, people have been trying to solve, physicians have been trying to solve for social determinants of health for a number of years. And this is not, going to make, I think, a material difference for those physicians. And the physicians who, have not been doing the work or feel like they don't, like if you didn't have time to do it when you didn't get $18, you're probably not going to have time to do it when you do get $18. And so, I guess I wish it was just a little bit more purposeful in terms of that, because I already see, as I'm sure many of you do, a lot of the E&M templates I work in now have a little social determinant of health area, and there's various pieces of information there, but it's very rarely tied together in terms of like, what are we actually doing to solve for this for the patient? And so my other concern is it just exacerbates that problem where we just have this little social determinant of health template in the note, and we say, well, they have social determinants of health, but we're not really doing anything about it. We're spending 5 minutes talking about it and nothing really changes. And so those are the things that I'm thoughtful about. It's just another, similar to G2211, that raises the risk that it's another potential thing that the physician says, well, let's try to get as many of these $18 as possible. And when the auditor from Medicare comes in, the juice is not worth the squeeze, as they say.
Right.
But I think, Scott, this may come from, a lot of providers have gone to CMS and said, we spend all this time doing this. We spend the time helping patients get the Meals on Wheels, or we help the patients try to get their medications. We troubleshoot with the pharmacies. That's probably, in my opinion, where this came from, was since you're already doing that and you're saying that we don't get paid for that, and you're decreasing our E&M services, but we're doing so much more for patients as the cost of meds increase and as services become available. So maybe that's where they thought of why this was a great idea.
Well,
but I could go the other way too. It could be that they just add it because they can add it, but hopefully it's because they really do provide those services.
I think that's a very good point, actually. And I think that what happens, and again, I could compare this to G2211 and how I think it's going to happen, because it's a modest reward for the providers who are doing that work. But then like a bunch of providers are going to like run through the fence and just start throwing it on all these services when they're not really doing the work.
We'll always have those bad actors, unfortunately. And for that, I think none of us will ever be able to early retire.
So. Well, that's the nice thing about it, right? Like every time I think, well, what if they solve all the regulatory problems? What will I do? And then like a new fee schedule comes out, and I'm like, well, I got another year.
Well, the other thing that we want to keep in mind, remember, it's not a screening. Remember what a screening is. No symptoms. There's nothing that shows the patient has this. They may be age appropriate where you think. So if an assessment means there's a problem, there's a social determinant of health that's impacting the patient's care. And like Christine said, you're taking the time to address it. So whether it be with an annual well visit or with an E&M service, it has to be something known. So if you're trying to put it on an annual well visit and the patient doesn't have a social determinant of health, I think you could see some kickbacks on that as far as not being paid for. Well, but I wanted to mention something real quick on this too. Remember when you see the MLN, whenever you see a transmittal that comes out, remember the effective date is when we can bill it. That's when we can report it. The implementation date, which sometimes is 6 months later, and remember the social determinant of health isn't effective until July 1st. As far one thing you just keep in mind, implementation means when the edits then kick in. When the payers have to start dealing with, can this be billed? Like we keep beating a dead horse with the G2211. Is there 25 modifier there? So because new guidance just came out in I think just the other day for the G2211 that said January 1st effective date, but February 17th or 19th, I think, that it said that implementation date. That means the edits have to be in place within their system. And so just make sure that you're not fishing. I see Pam says, how do they know the patient doesn't have a social determinant of health if they don't do the assessment? Remember, Pam, it's not an assessment if the patient isn't complaining of everything. Then it's a screening, and then you've got a gray area here where you have to be careful. You can't go fishing. It's like, how do you know the patient doesn't have a shoulder problem if you don't start looking at that, but they're in a urologist office? You can't do that. You can't start fishing and try to get paid for this stuff. So
Terry, I think that we'll see indicators for an assessment either in the social history of the patient or in that health risk assessment for the annual wellness visit.
I agree.
That's where you're going to see that trigger for the assessment.
Yeah. And remember that G0136 is defined as a standardized tool assessment. So you better be using a standardized tool if you want to build.
Absolutely, Paul. I heard that in one of these CMS stakeholder calls, and they're like, and they kept saying it over and over. And they gave you an example in their last webinar about that. I know I talked about it in my last Medicare webinar. So, but what's interesting, and then I know I've kind of taken up some time from everybody, but why is it that Medicare puts out how great we are? We're doing this, and I love Medicare. I'm not being negative, but then they give you the hammer at the end of the transmittal saying, "Oh, but it's not effective until 6 months later," or the new prior authorization. Look what we did. We fixed it, and everybody's going to have to do this, but it's not effective till 2026. I'm like, people. So in the meantime, what are we doing? So those kinds of things kind of are driving me crazy right now.
Well, it's the legislative piece of how these things work, and how Congress looks at budgets, how they try to maintain budget neutrality, how far are they willing to kick the can down the road. So I get the point that you're talking about, Terry, because you would think if you have a solution now, why are we not implementing it now to
exactly
the existing problem? But that's bureaucracy at its finest, and it's the carrot and the stick approach. And think of it this way: if Medicare were to do the right thing, if commercial insurance companies were to do the right thing, if state Medicaid programs were to do the right thing, where would be any of the fun in that?
It would be no fun. Well, we wouldn't have jobs because everything would be perfect, and we know it's not perfect.
And we know with the government, close enough is good enough. and that's not good enough for us.
Right.
All right. So our third and final topic for today, where are we going with this one?
All right. So this one is just I don't know. Maybe I'm becoming too cynical in my auditing days. I don't know. I kind of enjoy talking to my colleagues here, especially when Scott and I or Paul and I get this banter going. Even Christine and I will call each other going, can we just rant right now? Because how many of you see disclaimers in the EMR where the doctor says, this record is full of errors and I'm not responsible? So I'm just like, so I'm going to throw it back to my esteemed colleagues here.
Time to get a new doctor. That's what I
know,
say.
right? So Scott, I'm going to start with you. Do you see that in the records? I see it all the time.
I see it all the time, and I this isn't the best analogy or example, but it almost reminds me of like when I go to a baseball game and they're like, by the way, if you get hit in the head with a ball, like it's not our fault. But then there was that thing a few years ago, and like I think it was Texas, where the player was like, I'll just throw the ball to this fan, and the fan tried to lunge for it and fell over the railing, right? So there's always things, and I think in defense of the providers, I think they're trying to kind of CYA themselves on little spelling errors and things that a patient will probably overreact to. Like, how many times do I read a note where the patient is gendered like each way at different points in the note,
seen
right?
that too. Yeah.
I'll see like, his uterus, and I'm like, wait a minute, let me just make a quick check of the patient's name and make sure I'm in the right note here. And then it's like, oh, the person's name is like Samantha. It's okay. So I think it's just an error. But I think if you're a provider, I certainly wouldn't hope that in your mind, right, is like a catch-all because you provide, you dose the patient's wrong med. But the one thing I will say, you are responsible for the documentation and you are responsible for reading notes carefully. Like, how many times do we hear about things like medication errors, that happen where the patient actually ends up getting the wrong medication or getting the wrong dosage of a medication? And so I don't think that the intent of that disclaimer should be, well, I ran through this and I did the best I could and I'm on to the next thing. Like, you still have to read your documentation. I mean, how often now you throw in, well, how often is there like a scribe involved in this? How often is like somebody else creating the documentation and you're putting some disclaimer in there and you're not even reading it, right? You have like no idea what's going on. And so I see it all the time. And yeah, I mean, there's a bit of sort of, it almost makes me smirk a little bit, like, well, what awaits behind the curtain of this note? But on an important level, like, I think doing that for things like spelling errors is one thing. But look, just scan the note and correct things. I don't think anybody's going to be perfect. But the number of times I see things and it starts to tie in things that are maybe could be perceived by an external payer as more nefarious, right? Like, how often is a note carried forward so often? Like, I once saw a patient whose age was 3 years off in the HPI because they never bothered to update it. And so the patient's like 62 in the HPI, but 65 in their birthday. These are not good things.
Well, I had 82 in the update, but 8 years old in the thing, and I'm
That's
like
that's
an 8-year-old
that's
on all kinds of medications that you're like, that 8-year-old is not going to
well,
have a good day.
and then you see, and we've talked about this before. You'll see like the 8-year-old who's like consenting to something. Like, I explained to this 3-year-old like how the medication worked, and they said they stated they understood. So there are
I get
things.
doctors all the time saying that it's okay to say, I read the above, but I did not check for errors, and so basically, don't blame it on me.
Yeah, and I'll address some of the malpractice things here in a minute. But Paul, I want you to build off of a statement from Taylor real quick.
Yeah, so we have a comment stating that as far as syntax errors, there you go. It was always when providers were using Dragon, and I would agree that voice recognition software has come a long way since the early days, particularly that one neurological note where I saw that the patient had diabetic polyneuropathy and suddenly became, through the magic of Dragon, diabetic performed a rock with you. That was a fun one. But one thing that we have to keep an eye on as we go forward with these little disclaimers that come out is that now the curveball that's been re-added into this issue is AI created documentation. Now, we are way ahead of the point where AI can create reliable documentation. There are just too many errors. There are fraudulent things that are being cited as treatment protocols when they don't even exist. There's so many things about AI where, and particularly as it comes to clinical decision support, it's not there yet. It's many years away. It's probably not going to be here in my occupational lifetime. There's a hint for when I'm getting out of here. But honestly, if you are using AI at this stage, and far be it from me to tell you not to do it, but I'm telling you not to do it, and you insist on doing it, you better double check all the things that are in there and not just put a disclaimer saying, this might have some errors. Well, the errors are not so much spelling and syntax anymore. The errors could be in clinical judgment. The errors could be in clinical reference. And that is a very, very bad thing. And it leads perfectly into Sean talking about medical malpractice.
Yeah, I have throughout my career tried to stay away from medical malpractice. Um, it's gut wrenching. It's, to me, some of the most difficult litigation to get involved with because there's always a ton of finger pointing. And at some point, you know, people have to understand there's a reason why they call it the quote unquote practice of medicine. Medicine is not an exact science, it is an art. And I think one of the things that the government did start to push, which is really important, is patients being more engaged in their healthcare. Because at what point does a patient have to take some accountability and some responsibility to ensure that what they are hearing is precisely what the provider is telling them? And I think one of the things that I've spent a lot of time with the providers that I spend time with them in their offices is getting them to slow down. And I have a doctor, and he loves when I use his name. Dr. Stephen Soloway. He's a rheumatologist. He's a phenomenal, phenomenal physician. One of the things that I've worked with him on over the last several months, and it's changed the reviews that he gets online, the number of stars, how his patients feel about him. At the end of each visit, I have gotten him now to the point where he says, Sean, that's going to conclude our visit today. Before we do, though, I want to give you an opportunity to ask any additional questions. If there's anything that I have said that doesn't, fully compute, if you need some additional clarification, now's a great time to talk with me about that. But also keep in mind that just because you leave doesn't necessarily mean that your visit is over, because if you get home and you find you have questions or concerns, please call into our triage number. And it has made a significant difference in how patients are engaging with him and how he's engaging with his patients. Um, disclaimers. Um, a disclaimer is not a free pass to be lazy. A disclaimer is something that says, I am giving you all of the information and education that I have readily available for you at this time based on the conclusion of your diagnostic studies, the conclusion of your laboratory test, the conclusion of our physical examination, our historical, discussion. And based on all of that, my clinical judgment is X. But I will tell you, from the number of cases that I've been in over my lifetime, putting a statement into the medical record that says reviewed but not checked, or, dictated but not reviewed, it doesn't fly in medical malpractice cases. The courts have eaten that up. Juries despise it. if your providers are using statements that say dictated but not read or something along those lines, take them out.
Hey,
Because
Sean,
go ahead, please.
they should just, I think at that point, if they're going to take the time to add that into their EMR, then maybe just take it one step further. Email your malpractice insurance carrier. See if they support you adding that disclaimer into your medical records.
Absolutely.
There's no carrier out there that would ever say, that's cool, right? No. So if you're thinking of doing that, or if you have it in take that one extra step, reach out, get it in writing.
Yeah. No, I agree. And listen, I write a lot of disclaimers for things, and disclaimers are really written as a way to try to deter legal actions and people stealing stuff and things of that nature. But in medicine, you can't say you dictated a note, but that you didn't read it for its accuracy. Because if you put in there for a diabetic patient that they need to take prednisone for 5 days following a procedure, and somehow it goes to the pharmacy and they get, 75 days, and they take it and then they die because they're diabetic. I mean, that's a problem, right? That's not something that you can point at and say, well, I didn't actually go back and read anything. So you got to be careful with that kind of stuff.
Well, Sean,
Yeah, and
I
I
was
think
also involved in one where it's pacemaker insertions, where the providers, one of the rules on pacemaker insertions, and this was a big hospital system, and the attorney called me and said, "Can you look at these? We have a problem." And she couldn't figure out what the problem is because I used 3 coders. They don't know what the problem. And I found the problem. All of the numbers, the serial numbers that went with the pacemakers were the same. And I said, "Are we using the same pacemaker for 600 patients?" And I said, "How do you do that?" And they said, "Oh no, it was in the template thing, and it was the doctor put at the bottom of all these dictated but not read." And I'm like, it was their responsibility to know what serial numbers they used and what lot numbers are used for these pacemakers. And I don't even want to tell you
Terrible.
what the refund was. There
Oh,
was no going back. You have to do that.
absolutely. Scott, you were about to say something. Go ahead.
Yeah, it's pretty much the same thing. All errors are not the same. And Samantha has a great comment. I mean, it's not great for the parties involved, but basically that NDC and lot numbers have been found to be an error, and the result is an incorrect dosage is given to the patient, right? And that's an order of magnitude different than saying that someone who is 62 is 64 or vice versa in a chart. And my feeling in some of the conversations I've had with providers in the past and some of the administrative folks I've worked with is that a lot of these disclaimers are, I don't know if well-intentioned is the right word, but you never really know what a person's going to react to, right? Like we all see those videos online where people get their order wrong at McDonald's and they jump behind the counter and start beating the person up. And I'm just, you never really know, right? But all errors are not the same. And I think they're trying to stave off calls and things like that. But in reality, people get the wrong dosage. Like people, may have a surgery done on the wrong limb or something, right? And so this is critically important stuff that you can't just disclaim your way out of, I think is what I wanted to say.
And I have a question for you, Sean, since you do so much defense work. So, how often can you say, or have you seen where somebody has tried to say, because I get this not from a legal perspective, but I get this in the office a lot, and it makes me crazy. But again, from a legal perspective, because I'm not an attorney, and I know you're not either, but I know you are involved in a lot of these legal cases. When somebody says, "Well, you knew what they meant to say," how does that fly?
Yeah. You know, saying, "Well,
I know.
you know what they meant." No, I don't, because if what's written on the piece of paper is on the piece of paper, then I have to take that as your intent. Um, I it's like CMS when they say, we can't infer things, but diagnostics, if it's easily inferred, that's the reason why the doctor was ordering something, then we can easily infer diagnostics, but we can't infer something to help determine medical appropriateness, necessity, or reasonableness. It's got to be clearly documented and stated in the record. Um, this is why, well, throughout my career, I've always been very selective on the cases that I take, but even now more so, before I agree to a case. Myself and Paul, especially Scott on some of the cases, Stephanie on some of the cases. I know Terry, I've gotten you involved in some of my cases. Um, you know, that's why I like to review as much of the evidence in advance before I say, yeah, this is a case that I believe we can help you. So Christine, you said you had a question for me.
I think that was Terry that had the question
That was
for
Oh,
me.
that
you.
was Terry.
That
I'm
was
sorry.
me, yeah. No, but
Your
Christine
name
and I
was
have
above
this
it. I'm
yeah,
sorry. I
no,
apologize.
Christine and I have the same conversations, though. There's times when
Yeah.
I'll read a note and I'll text her and say, "Do you have a minute?" And luckily for me,
Yeah.
sometimes she does, sometimes she doesn't. But I'm just like, "Am I crazy here, or is this not okay?" And by the way, everybody, yes, we have a BAA and a HIP agreement,
Yeah.
but
And,
it's just sometimes
yeah.
weird. Sean, you and I have the same conversation. You're like, "Terry, am I crazy here?"
Yeah.
Because we can't believe it.
And here's what I would like to say. Obviously, the four of us and five of us, or six of us really, when Stephanie's on, we collaborate on a very regular basis. We are always engaged with each other. Yes, our organization, Doctors Management, has business associate agreements with Terry Fletcher Consulting and with Sterling Global, Christine's group, so that we can have these conversations. But I always try to push this out there to the good folks who are listening in and following us on the live stream or listening to the podcast. You've got to create your circle of trusted resources. Don't start sending medical records to each other if you're in different companies without having some kind of business associate agreement and formal relationship. But to pick up the phone or to drop an email to say, hey, I've got this case that I'm working on, or this audit that I'm working on, or this situation that one of my clients reached out to me and it's a little funky. And here's kind of my thoughts on it, because so much that we do each and every single day in our job is subjective. And there's a lot of different opinions that are floating around on the exact same topic. Tomorrow, I know Terry and I are going to have a very interesting conversation on cloning. That's our topic for our hashtag Terry Tuesday tomorrow. And I'm looking forward to seeing where Terry and I mesh and where Terry and I maybe slightly differ in our thoughts on cloning and cut and paste information into a medical record. So stay tuned for that. All right, so let's go around real quick in the last few minutes that we have together. Paul, I'll start with you for any final thoughts or words of wisdom.
Actually, this was a very good episode, and I'm left speechless. I have nothing to add. I think I've said everything I need to say. I'll leave it to my fine colleagues to sum up.
All right, Christine Hall.
Well, I just wanted to remind everyone, we've got some documents out there to help us with our G2211. I know we talked a lot about it last week, but make sure that you're checking the new document that came out this past week, and some great examples there.
And I know we put that into the link for everybody. Scott, final
I
words?
I just want to build on your last comment there a little bit, because I think the subjectivity of our work is important. One of the things that I've had providers tell me before, when I talk about all of the bad things that could happen to them, is like, I will never get audited, much in the same way that I say, like, I will never win like the Powerball, or I will never win like a big lottery jackpot or something like that. And I think a lot of the work that we do, whether you're working in an individual site or doing the work that we do, for me, like, I think my work starts with essentially like a philosophy of compliance that I try to apply to everything that I do, right? And I think once you deviate from that philosophy too much, that's where you run into trouble. And I think as you talk to more people, as you see people in practices and physicians, a lot of this has to do with risk tolerance and philosophies, right? Like, some people jump out of airplanes, like some people don't. And I think that's an important thing to think about when you're in a situation, whether you're within a practice or not, and you think about, this doesn't feel right to me. It's probably time to think about it and think about where you want to be. I don't know if that makes a lot of sense, but I think, when Sean said that, that's what I got to thinking about how I try to approach the work that I do. And I think, I don't want to speak for the panel, but I think a lot of us are that way.
All right, and to you, my good friend Terry Fletcher, I will give you the last word.
I agree with everyone else. This has been a really good session, really good episode this week, and I really appreciate being a part of it. I think I would just say to the listeners, to the watchers, to everyone out there, remember that as much as we like to bring you information through the podcast, and I know there's information on LinkedIn and social media has a ton of information, it's still up to you to make sure you are taking educational sessions, webinars, and live conference sessions and things like that. And I know we all offer them either through Doctors Management, through my company. I know Christine has them as well. But this is great and it's conversation, but you need to have some things in writing. And if you can't find them, those educational sessions have them for you, because I'm telling you what we say here is awesome. And I know we're trusted consultants, but your providers are going to say, where'd you find that? And we do put some things in the chat as far as links to things in writing, but it doesn't always give you the application except for what you heard. And yes, you can find this on every platform. But again, you need to have the educational tools. Try not to just clickbait things and listen. And we really would like to see you attend some educational things.
All right. And that's going to do it for this Coding and Compliance Roundtable. Terry and I will be back with our hashtag Terry Tuesday episode tomorrow. As I talked about, we're going to be going over cloning, cutting and paste, carry forward information. And then I am so excited. I get my first run of the legal roundtable with Legal with Lyles Parker this week with Ashley Morgan and Robert Lyles. We have such an incredible program lined up for you all this week. So looking forward to hearing your feedback. Stay in touch with us. Keep the comments coming. Send in your questions, and we will do our best to get those topics onto the air, show your questions, try to answer them for you live. So, as I said, until we meet again, be good to yourself, but more importantly, y'all be good to each other. Take care.